that, yes, there it is. We have another year of talks. We're quite excited to begin the year with Chanda Martens, who is a colleague of Alexa and mine. And her topic today is home oxygen and CPAP, which I think some of you have experience with. So we're quite excited for this talk. I just wanted to note next month's talk, which is February 19th, is Harmonica and COPD health with two familiar faces I'm sure some of you have seen. We're quite excited to have them on. We've been trying to get Jacqueline and Tracy on. So please make sure to keep your eyes out for the registration for that as well. That's on February 19th. Without further ado, let me introduce Chanda before she starts talking. Okay. Chanda Martens is an RT that has been practicing for, well, let's just say a little longer than Alexa and I, about 15 years. And she has done everything. She has worked privately, so she's worked with private companies treating people with oxygen and CPAP. She's worked with health authorities in community roles, and she's now back in the acute care world after deciding that she needed a little more excitement in her life, maybe.
Or
One thing
punishment.
yeah, punishment, perhaps. Yeah. One thing that Chanda always shares is that no matter what role she is in, educating her patients and her clients is her drive. And so that's why she is here today, taking time away from her family, having a nice coffee, and maybe a nice book. So that's all I'm going to say about Chanda. Let's let her jump into it. Chanda, thank you so much. And the floor is yours.
Thank you. Thank you. Super excited actually to do this morning. I haven't had a whole lot of chances to do education, like formal education in a while. So this will be good. Can everybody hear me okay? Am I speaking up enough? No, Lindsay was having a little trouble earlier. We're good now. Right. See if I can share my screen and we'll get going. Okay. I hope everybody can see this. Yes, we got a thumbs up from Lindsay. Perfect. Okay. So for starters, here's kind of the layout for the presentation, right? So we'll talk a bit about CPAP therapy first. For starters, what is OSA or obstructive sleep apnea? Signs and symptoms, associated health risks that go along with it. The testing kind of and how it works. What is CPAP? The funding, how a CPAP trial works. So how do you actually get from the point of being diagnosed with sleep apnea to getting a machine of your own? And then what the follow-up for that looks like. Then we'll get into sort of the oxygen therapy side of things and go through the diagnostic testing and funding and equipment for that. Okay, so CPAP therapy and obstructive sleep apnea. So specifically, I'm just going to minimize this, sorry. There we go. Talking about, there are different types of sleep apnea, but we're going to talk more specifically about obstructive sleep apnea. And for starters, it's important to know what an apnea actually is. So an apnea is actually, is that still sharing okay? My screen jumped around, sorry. An apnea is actually defined as a cessation in breathing for greater than 10 seconds. An apnea might or might not be associated with a drop in oxygen levels. It's totally just dependent on the patient, on the person. However, I will say that the longer the apnea goes on, certainly the chances of having a drop in oxygen level goes up. In the case of sleep apnea, those apneas are actually normally associated with an arousal, meaning you come out of a deep sleep into a much lighter sleep stage. The two main types of apneas are central apneas and obstructives. We're going to focus mainly on obstructives, but the difference is a central apnea is when your brain doesn't tell your body to breathe appropriately. And an obstructive apnea is actually when your airway is collapsed in on itself. So your windpipe is collapsed in and it doesn't allow you to move any air. What causes an obstructive apnea is that kind of when you fall asleep, all the little muscles around your airway that support it, that have tone when you're awake and hold it open, well, they all relax like the rest of your body. And unfortunately, that means they sometimes relax to the point of allowing your airway to collapse in on itself. Obstructive sleep apnea is a very cyclical thing too. Throughout the night, you'll have apneas over and over again. As you nod off, you lose muscle tone, you'll obstruct. That causes a little bit of a stress response in your body or a fight or flight response, which rouses you enough to get muscle tone back. So you draw your airway open and breathe appropriately. And then eventually you will nod off again and do this all over. Thing is going on with my sharing.
It kicked out, eh?
It did.
Oh, and
That's
then
okay.
did it kick back in?
I'm kind of in the middle of fixing it. There. We see it again?
Is it, I can see it again? Yeah.
Okay, perfect. Not sure what's going on there. I haven't used Zoom in a while, so that's probably operator error.
No, it's
Okay, signs and symptoms for obstructive sleep apnea. I'm betting a lot of you have heard these before. So excessive daytime sleepiness is often associated with obstructive sleep apnea, but not always. Snoring as well, especially very heavy snoring, is often associated with sleep apnea. Waking up feeling like you're choking or gasping or snorting yourself awake. Getting up to pee a lot at night is actually can be a sign of sleep apnea as well. Again, not always, but can be. A very restless sleep, high blood pressure, and weight gain can also be all associated with sleep. Okay, associated sort of health risks for sleep apnea. So this is if you have sleep apnea that you leave untreated for an extended period of time, puts you at higher risk of things like heart attacks, strokes, atrial fib, weight gain, type 2 diabetes, high blood pressure, and the list goes on and on. It's definitely one of those things that once you've identified the problem, it's worthwhile generally treating. Even if you don't have the daytime sleepiness associated with it. Now, most people tend to measure the success of treating their sleep apnea based on whether or not they're, well, I'm tired, I'm not tired during the day, so I don't really need the CPAP. And the fact is, even if you're not tired during the day, there are still all sorts of other things going on with your body that really should be addressed. Okay, so what does the testing look like for sleep apnea? So in the picture, you'll see a typical sort of at-home sleep test. This would be considered a level 3 sleep test. We don't use overnight oximetry anymore, which is, I'm sure you guys all know at this point, is the little finger probe that monitors your heart rate and your oxygen levels for the night. That's only really good for checking your oxygen levels, right? So we can't use it to diagnose sleep apnea because it doesn't identify an actual apnea. What it identifies are desaturations in your blood oxygen. Okay. Sometimes having low oxygen levels on an overnight oximetry might be enough to spur your doctor to order further testing, but we can't actually diagnose anymore based on overnight oximetry or what's considered a level 4 sleep test. Home sleep apnea testing is great if you have very sort of straightforward obstructive sleep apnea or suspected straightforward sleep apnea, not much else going on in terms of health issues. However, a full sleep study, which is considered a level 1 or a polysomnogram, which is done in a sleep lab, typically in a hospital, but sometimes in private setting as well, are for the more complex sleep apnea. So if your physician has reason to believe that there's maybe some central sleep apnea mixed in with the obstructive, or if you have a history of heart condition, or sometimes our patients with higher BMI, right? So a higher body mass will also be more appropriate to go through the lab, just because the level 3 testing doesn't always tell the full story. And then there are different types of sleep studies as well. Just for your own knowledge, there are diagnostic studies, which means you go into the sleep lab and they wire you all up, and they get you to sleep for the night, and they do nothing but monitor you for the entire night. Then there's something referred to as a split night study, which means they gear you up and you sleep for the first half of the night and they monitor you. And then they actually put you on treatment if it looks like you need CPAP or BiPAP for the remainder of the night and adjust the settings based on your needs. Those are tough to get where I live right now, but we do them. Okay, so CPAP therapy. CPAP actually stands for continuous positive airway pressure. And that's exactly what the little machine does. It gives you a constant pressure through a hose and a mask that you wear at night that's meant to basically splint open your airway so that when you relax and go to sleep, it doesn't allow for it to collapse in on itself. So you can breathe and sleep properly. There are a couple of different types of CPAPs. One of them is an auto CPAP, which means it adjusts the pressures for you during the night depending on what you're doing. Its goal is to always maintain the lowest possible pressure, but still keep an open airway for you. So it's monitoring your breathing and then adjusting for it. And then there's also straight or constant pressure CPAPs that just maintain one pressure all the time during the night. And while they sound less complex, they sometimes work better than the auto machines. Lots of different mask options now. You know, it wasn't that long ago when we were sort of limited to your basic full face and your basic nasal mask. That is a thing of the past. We can go from full face now, which covers your mouth and nose, to a nasal mask, which covers your nose, to direct nasal or nasal pillows, which actually seal kind of on your individual nostrils. And then there are also below the nose or cradle masks now that just kind of sit underneath of your nose and create a seal. There's also combinations thereof, some that cradle your nose and cover your mouth at the same time, that sort of thing. So lots and lots of different options. So you're not, you're kind of not stuck, right? If you try a mask and it doesn't work well for you, you can always work with whoever your CPAP provider is to find something better for you. So these are kind of a few basic examples, right? The one on the top is a full face mask. Bottom right is a good example of just a nasal mask. In the middle is a cradle, and on the left is an example of nasal pillows. Okay, so what does the sort of funding look like for CPAP therapy? If you're paying privately to get a machine and sort of all the consumables that go with it, and by that I mean tubing, filters, mask, typically, you're looking probably out the door somewhere around $3,000. You might be a little shy of that, but that's pretty close. The good thing is if you have extended health coverage, which I think a good deal of us do now, they generally cover about 70 or 80% of the purchase price for your CPAP. They will also cover supplies for you, or 80% of supplies, once a year. And then a new purchase of a new CPAP unit, usually every 5 years. That's kind of a typical coverage. If you're very lucky and you have extended health that has a cap, which means, so say you're at 80% up until $2,000, and you spent $2,000 already this year, you might actually get the CPAP covered for 100% because it'll flip over to 100% coverage after that. So often tail end of the year purchases of CPAP can actually have better coverage. In order to get coverage through your extended health now, and this is new in the last few years, they actually want at least a level 3 sleep study or better. So we're looking at level 3s, which is the same as what we had in the picture earlier, that you can do at home, or a level 1 sleep study, which is done in a sleep loop. They do want the diagnostic testing now to cover you. Didn't used to be the case. There's also funding for CPAP for anybody who's on social assistance. So through the Ministry of Social Development and Housing, they will also cover it. The rules are slightly different to get funding for them. They will do it. They also need the diagnostic, and then they will fund kind of an extended trial and a purchase of a machine as long as the patient is compliant. As long as you're using the machine lots, they will fund the purchase of one. First Nations Health Authority will do the same. Very similar. They want the diagnostic, and then they will fund a trial, and then based on how well you do during the trial, they will go on to fund the purchase of a machine. The funding is complicated, and you certainly don't have to remember it. It's just to give you an idea of what's going on behind the scenes while you're doing your trial with your provider. They are scrambling to get you funding. This is their thing to worry about. Most CPAP providers are all that I know of. In fact, I don't think it's legal in Canada to sell a CPAP machine if you don't offer the follow-up service that goes along with it. Most CPAP providers offer a CPAP trial. Typically during the trial, you would have to purchase your own mask, tubing, and probably the water chamber as well that goes with the machine. Those are kind of considered consumables. But you get the use of their CPAP machine. And then they have you in for regular follow-up, or they can do it remotely now as well, just to make sure that the settings are adjusted. They can troubleshoot any problems you might be having, that sort of thing. Occasionally, they may also want you to come in for a face-to-face visit, especially if you're struggling with a mask fit. Mask fits are hard to do over the phone. So sometimes there's no substitute for that face-to-face appointment. A typical trial lasts for 30 days. So if you're paying privately or you're going through your extended health, usually you'll do a 30-day trial. Now that sometimes gets extended a little bit if you're waiting for funding to finish up. So you can go right straight from your trial to using your own machine, but around 30 days. Government funding, so we're talking now about the ministry and First Nations Health Authority funds 60-day trials, so 2-month trials. In the middle of that trial, so at the 30-day mark, they want a compliance report, which means they want proof that you've been using the machine for at least 4 hours a night, 80% of the time, okay, in order for them to fund a purchase for you. Once the trial is completed, then you can go on to purchase your own CPAP machine. So follow-up for CPAP therapy is actually pretty simple. It's either once a year, typically, which gives them a chance to your provider to check your settings and for you to purchase any of your supplies. So mask replacement is recommended at least once a year. And then you can pick up a new tubing once a year if you want to, filters as well for the year. Those are kind of the typical replacement things. But also gives a chance to tweak any of your settings if that needs to happen, to do an overnight oximetry to check oxygen levels if that's warranted, all those sorts of things with your provider. You can purchase supplies as well online. I would be remiss to not mention this because I think everybody likes to do their shopping online now if they can. And you can often find a better deal online on the supplies than you will from your provider. However, I would recommend even if you're going to purchase supplies from an online source, I would shell out and buy the machine at the very least from a provider. So you get the experience of going through a trial, having somebody sort of be a resource for you if you're struggling. It's always the most difficult part of getting used to the CPAP is that initial phase, right? That first month is pretty crucial. So it's nice to have them as a resource to troubleshoot, tweak things, all those sorts of things, answer questions. And sometimes just to cheer you on because it can be tough. Okay, moving on to home oxygen therapy. This guy looks really happy to be on oxygen. Okay, so for starters, we use oxygen to treat something that you'll hear referred to as hypoxemia. And what that actually means is just low oxygen levels in your blood. So a normal oxygen level for, say, somebody who's in their 30s or 40s with perfectly healthy lungs is going to sit about 97 to 100%. It depends on the person, depends on what they've been doing. However, that does decrease slightly with age, and it certainly decreases with health conditions. Our goals, however, to be safe and to make sure that, in particular, that we're protecting your heart, just to keep you above 88% all the time. That's kind of our arbitrary cutoff is 88. Okay. So the goals for home oxygen therapy is typically also to keep you above 88. Oxygen levels less than 88 on an oximeter, would be considered hypoxemia. Shortness of breath is, believe it or not necessarily a sign or symptom of hypoxemia. Okay. Until we have sort of critically low oxygen levels in our blood, we don't typically have an increase of shortness of breath because of it. Now, that's not to say it never happens, but typically at levels where you're up and about and walking around and feeling pretty decent, your shortness of breath is not coming from low oxygen levels. It's coming from a mechanical issue with your lungs. Whether you have COPD or you have interstitial lung disease, you have something that's changing the mechanics of your lung and your ability to get oxygen into your blood. So it doesn't have anything to do necessarily with the actual low oxygen level. You're just working harder to breathe than somebody with perfectly healthy lungs. Kind of an important distinction there, right? Shortness of breath is not low oxygen. They are not the same. Another sign or symptom of hypoxemia could be something called cyanosis. I'm sure you guys have all heard about this one, but that's that blue tinge that we sometimes get to our lips, to our nail beds. It can even happen sometimes under our eyes with low oxygen levels. You can have decreased muscular endurance or almost feeling as though your muscles are a bit heavy, like almost like you've had a workout already, but you haven't done anything. Tachycardia can also be a sign, right? As your oxygen levels drop, your heart rate will pick up to make up the difference. It tries to recirculate what you do have in your blood that much faster to make sure all of your tissues and organs are getting the oxygen that they need to do what they need to do. Dizziness can definitely be a sign. Confusion, sort of that mental fog that people feel. It's a thing with low oxygen level. It definitely can happen. There's a number of other ones, but we'll end there. Treatment for hypoxemia, if it's, not something that's resolvable, would be oxygen. But definitely if you have low oxygen levels because, say, you have a cardiac condition, or maybe you have a pneumonia or something like that, we tend to go to treating that first, right? With antibiotics, cardiac meds, sometimes lifestyle changes to avoid exacerbations. If you have something like COPD or ILD and we want to avoid flare-ups as much as possible. This sort of treatment phase can often include a little bit of a stay in hospital, just depending on how low your oxygen levels get. It does look like it's going to be a chronic sort of thing, though. You're going to require oxygen for a longer period of time than you need to be in the hospital. Then we start looking at supplemental oxygen for you to use at home. So the testing for whether or not you need oxygen to go home are usually, well, blood gases anyway, are only done typically on admitted patients, so patients in the hospital. Oximetry can be done as well to qualify you for oxygen funding for at home. As an outpatient, we can do this. They'll either do resting oximetry or exertional, which means we might get you to go for a little bit of a walk and monitor your oxygen levels to see if you need the oxygen when you're exerting yourself. And then we can also check you specifically at night. Some people are great during the day. They're fine when they move around. They're fine when they sit still, but especially I notice this the most, I think, probably with heart conditions. Oxygen levels can sometimes be a bit lower just at night. So there's all sorts of variations on how you might need oxygen, whether it's all the time or maybe just at night, that sort of thing. I don't know if any of you have ever had an arterial blood gas, but it's not nice. Most people hate these. We do them as little as we can. But this is the way to qualify you for funding for oxygen if you were being discharged from hospital and needed it all the time. This is done at rest. You have to be completely at rest for at least 10 minutes prior to the poke, and off all of your oxygen if they have you on oxygen in the hospital for at least 10 minutes prior as well. The qualifying sort of criteria for it is lower if you don't have any comorbidities. And by that, what I mean is we're looking for oxygen levels in your blood to be at a certain level to qualify you. If you have cardiac comorbidities, so say like congestive heart failure or pulmonary hypertension, then the number we're looking for is actually slightly higher, just because we want to be extra careful with anybody who's got kind of a vulnerable heart. Okay. Yeah. So yeah, typically in BC anyway, outpatients will often have the outpatient oxygen assessment, which could be a blood gas, a walk test, overnight oximetry, all of that. But if you're in hospital and being discharged, we go right straight to a blood gas generally to check you. So for home oxygen funding, requires qualifying data and a prescription from your doctor, which typically is pretty easy to get as an inpatient, right? Because we can track down the doc and get a signature pretty quick. Sometimes takes a few days if you've been referred as an outpatient. That's sort of what we need to send off to the home oxygen program, or you hear it referred to as HOP. It's the government program that will pay for your oxygen in BC if you do qualify. Am I looking at here now? There's also extended health benefits. Sometimes we'll pay a portion of oxygen, as well as First Nations Health Authority, or you can pay privately. So if you don't qualify for that HOP funding, for the government funding, there are sometimes some other options. You can pay out of pocket, or you can run a part of it through your extended health. And if you have First Nations funding, then they will pay 100% of the shot for you with only a prescription. They don't need any qualifying data. Okay, so how do you get started on home oxygen? Home oxygen providers may or may not have a government contract to supply oxygen for you to use at home. There are a few different companies that you could go with. In BC, we do have a contract with two oxygen providers, one main provider, which typically gets all the discharges from hospital, and a secondary provider as well. If you had strong feelings towards one or the other, you certainly can choose, but otherwise, we typically send everything from hospital to one and outpatients to another. Typically, they also have either, as far as I know, they can only employ either RTs or RNs to do their respiratory assessments. It's not in an LPN scope of practice. So it's either a nurse or an RT that would be assessing you if you end up on home oxygen through the provider. Home oxygen may be used 24 hours a day or only at night or with exertion or a combination of all of those things. It just totally depends on the patient. In BC, if you qualify for oxygen funding for 24-hour-a-day oxygen, so say you're being discharged from hospital, you've had the blood gas, you qualified for the funding, and we send off all the paperwork to the provider, they have 4 hours to get to you from the time of your discharge or arrival home to set up equipment for you. In the interim, we send oxygen cylinder home with you to get you through kind of your wait until they show up to set everything up. We do occasionally also have what we refer to as quick discharge equipment that we can send home with you if for some reason the provider can't get to you. So say you're way out of town or something like that, or it's in the middle of a blizzard, or there are all sorts of reasons to do it, just to make sure you have everything you need. Either way, they will see you within 24 hours of your discharge to have you assessed at home on the oxygen equipment that's been provided to you so they can adjust your therapy to suit you. When we send you home with a prescription based on what you were on in the hospital. But the equipment at home can sometimes be a little bit different. So the therapist, when they assess you at home, will be able to tweak the settings on that machine and give you the actual settings you should be on all of the time based on your current needs. Reassessments then happen sort of periodically afterwards. Okay, so if you need oxygen 24 hours a day, typically what you'll have set up at home is something called an oxygen concentrator, which is a stationary machine. It's on wheels, which is good because you won't have to lift these guys. They're typically somewhere around 35 pounds or so. Some of them are as heavy as 65 pounds. So they are thought of as being stationary machines. You sort of park them somewhere central in your house and then use your oxygen tubing to get around with so you're not constantly moving it. They draw in room air and they just filter out the oxygen to give to you, and then they kick the nitrogen that they've separated back out into the room. Okay, so as long as they're getting power and as long as they're being properly serviced and running accordingly, then they just continue to give you oxygen all of the time, similar to the wall outlet in the hospital, just not with as much pressure. Then you also end up being set up with portable oxygen for when you're getting out and about, being active, which could be in a couple different forms. And then there's all the tubing, so all the cannula, all the long tubing, any connectors, all of the things that you'll need to go with it for supplies. If you're only using oxygen at night, then typically it'll just be the concentrator and the software, which software I'm using that word to refer to the tubing and cannula. And then exertional only. So if you only need it when you're up and about and exerting yourself, walking, then you have portable oxygen and software set up. So that's that picture is kind of a typical concentrator. This little guy weighs somewhere around 31, 32 pounds, I believe. It's kind of like carry-on suitcase size is about the size of it. Stationary units, like I said before, they're not really meant to be carried around. They're to be used in your home. They do need a power supply. They filter the oxygen out of your room air and deliver it to you. There are 2 different types of models. There are some that only go up to 5 liters a minute and some that will go all the way up to 10 liters a minute. It just depends on what you need for a prescription, and your provider will install whatever's appropriate for you. And then they can be used with up to like 50 feet of tubing. So generally, if you park them somewhere central, 50 feet of tubing for most people is enough to get them all the way around their place. That way you don't have to keep relocating the thing. Portable oxygen has lots of options now. Generally, There's two main options though, cylinders and what we refer to as POCs, or portable oxygen concentrators. So the pictures you're looking at is actually a portable oxygen concentrator. They weigh in the vicinity of about 7 pounds-ish and are about the size of a kind of a medium-sized purse. Okay. So they're not super light, but they are fairly compact, which makes them a little easier to get around with. Um, they're not appropriate for everybody because they deliver their oxygen with a pulse dose, which means you have a cannula that you wear in your nose, or prompts. When you take a breath, you cause a drop in pressure in the tubing that triggers that little machine to give you a puff of oxygen, a little burst. That can be adjusted so that the puff is actually bigger or smaller. But for some people, that pulse dose just isn't quite enough to hold their oxygen levels up. They need the continuous flow of oxygen that they would get from something else. So in order to have one of these, best to be assessed by an RT or an RN to make sure that, number one, you can in fact trigger it. And number two, it's enough to hold your oxygen levels up. Okay. Good thing about these guys though is they're battery powered. You can charge them with AC or DC power, which means you can plug it into like the 12-volt adapter in your car, or you can plug it into a wall outlet at home to recharge it. In a perfect world, you'd get about an 8-hour sort of life out of a double battery on them, a 16-cell battery. The faster you breathe, the faster that battery will drain, and the higher your dose. So it's always a little different. Your other option for portable is off to the right-hand side there. That's kind of behind a little picture, but those are oxygen cylinders. That's generally the go-to for anybody that needs a continuous flow of oxygen while they're exerting themselves. A little more cumbersome, but if you have the shorter cylinders, you can in fact get a shoulder bag and carry them over your shoulder if you're able to. If not, the bigger cylinders, you can get a cart for, so you're not worried about carrying them all the time. The short cylinders that I'm talking about are referred to as D-size cylinders. They sit about knee-high from the floor, and they also weigh somewhere in the neighborhood of about 7 pounds. So comparable to the portable concentrator. The big difference, though, is that they hang a bit lower. So even if you have them over your shoulder, a lot of people don't like carrying them that way because it tends to bang against the side of your knee. Seems to be where it hits most people. Carts, I think, are probably a little nicer, but you could also have a combination of things. Depending on what your outing is going to look like, you might choose one or the other. The downside to the cylinders, or another downside, is that you have a finite supply of them. So when you go through your supply, you have to make arrangements to either swap them out for more full cylinders or wait for your delivery day to get more cylinders, depending on what kind of setup your provider has. So that's the disadvantage of not having the battery power. Okay, but for some, they're kind of the only option. They're the best option. Okay, so move this out of the way. As far as like follow-up goes for oxygen in home, your provider, so that's the company that will set you up with oxygen equipment, will see you for your initial assessment. So that's within 24 hours of you being set up with the equipment. They will see you, if you need it 24 hours, they will see you for an assessment. After that, typically the home oxygen program takes over follow-up. A pretty typical sort of follow-up for the home oxygen program would be to see you at the 3-month mark, 6 months, 12 months, and then once a year thereafter. Once you've been on oxygen for a year, you're pretty stable on oxygen. We're pretty sure you're going to stay on it long term. They drop the assessments down to once a year or as needed. If you were needing to be reassessed sooner, certainly the HOP therapist could see you sooner. Okay. The funding can vary things a little bit. If you're going through your extended health, the sort of follow-up changes a little bit because there's no HOP involvement. So now your provider is doing the follow-ups. Again, typically that would be once a year. And then if you're paying privately, we're really down to an as needed sort of basis because you will pay for each assessment that you get. Okay. First Nations funding is a little different. Again, it's more similar to other extended health funding where your provider is actually going to do the assessment once a year, and either the extended health or First Nations funding will pay for your supplies. A whole other software package for the year. And that's kind of the gist of it.
Perfect. Thanks, Shanda. Um,
Mhm.
do you want to leave your presentation up or do you want to
Sure.
start your screen? You might want to
That's
bounce
totally
back.
up to you.
We did have one question so far in the chat from Wayne. He just joined a little bit later
Okay.
and he just wanted to know if you live on your own, what are the signs or kind of triggers that might suggest you to investigate having sleep apnea if you were living by yourself? And I know you chatted about, frequent wakes at night. Did you have a slide for that? I've already, oh my goodness.
Mm-hmm. Yep.
And then
Let's
at least we
see.
can just review that for weight because I think that's important. A lot of us tend to be on our own. And
Mhm.
how do we know that perhaps our airways are obstructing? Nobody's there to tell us that we're noisy snorers or that we're gasping for breath. So I'll let you take
Yeah.
it back.
Yeah. So this is probably the most appropriate slide, right? This is the signs and symptoms. So the big ones are being excessively tired during the day, like sleeping and then feeling like you haven't slept at all. Another sort of tip off that you often hear is people don't sleep well at night. They feel like they haven't slept at all, but if they lay down and have a 20-minute nap, they feel great. So what's happened there is when you sleep at night for longer periods of time, you get into something called a REM cycle. So these are different sleep cycles. In REM sleep, you have a very, very active brain, but you essentially have a paralyzed body. So that means your muscles are extra flaccid. You're way more prone to having obstructive apneas during REM sleep than in any other sleep stage. In order to get into a REM cycle, you have to be asleep for longer than 20 minutes. So if you're having that short little 20-minute nap, you may never be getting into REM sleep and you might not actually be having much for apnea. So sometimes people feel better rested with that little cat nap than they do with sleeping all night, just because they haven't obstructed. Again, snoring, but if you don't have a bed partner, you might not know. Waking up, choking, gasping, snorting, getting up to pee all the time at night is a big one. Tossing and turning a lot in sleep can be one, but not all the time. And then if you have kind of persistent high blood pressure that doesn't seem to respond to meds, sometimes it can be a sleep apnea issue, only because we're not kind of fixing the problem by giving you high blood pressure medication. We're just band-aiding a symptom, right? So it can be quite persistent, sometimes doesn't respond well to meds. And then sometimes a persistent weight gain overnight too, just because of the hormone dysregulation that goes along with the sleep apnea. Did that answer the question?
Somewhat, yes, thank you.
Yeah.
The idea of snoring, who can tell? I've never woken myself up snoring, but
Yeah.
uh, and
Yeah, that's a hard one. If you don't have a bed partner, it would be hard to identify snoring. Unless you've caught yourself like snorting yourself awake. That's probably because you were snoring. Yeah, I've actually had people record themselves
there's an
as
idea.
well to listen for it if you think you may snore. Waking up with a really sore throat is another one. People who snore tend to mouth breathe a lot, and they also tend to have a very sore throat from the constant obstruction and vibration that's going on during the night.
I find very dry mouth because of the oxygen that I'm on.
Yeah.
So I'm not sure whether it's a good dry mouth or cause or not. You know.
Yeah, it definitely could be could be a bit of both. Yeah, if you're on supplemental oxygen, it definitely will have a tendency to dry you out a bit. If how much oxygen are you on, Wayne?
I'm on 4 and 5 exertion.
Yeah, yeah, four is enough. Four is enough to make you feel dry. Yeah, that would be a hard one again to sort of tease apart because potentially the oxygen could be giving you the dry mouth, or it could be that you're snoring with your mouth open. Do you get a sore throat?
No, no, no. It just dries right up to the point where I have to get something to drink. You know. So,
Okay. Yeah, that would be a hard one to tell. And honestly, Wayne, if you were concerned about it, it would be super simple to talk to your doctor and get a referral to be tested. Like if you have some of the other symptoms, even completely ignoring the snoring factor, to get referred to do like at home sleep apnea testing. It's a one night thing, wear it at home, take it back the next day, and your provider takes it from there.
would that be the respirologist or the family practice? for the
Family doctor is fine, but if you're seeing a respirologist regularly and you want to deal with them for it, you could also do that.
Okay, thank you so much.
Absolutely, no worries.
Thanks, Wayne. Chanda, I'm going to get you to unshare your presentation just so then we can get some faces to pop up. I received another question, and this one, I'm just going to read it out loud. This is from Brian. So how low and for how long can your body sustain low blood oxygen? I can have down to 65 for a few minutes and then recover to 88 plus.
You said it was Brian?
Yes.
Brian, is that during the day, or are you like monitoring with a smartwatch or something overnight?
With during the day with very minor exertion.
With very minor exertion. And you're currently on oxygen?
Yes.
Yes. Oh, and you're still desatting to 65 with exertion.
Yes. Yes,
Okay.
but I must say I'm only going at low levels of oxygen. I haven't actually turned it up to a level 5 yet.
Okay. So when you initially got the oxygen or anytime recently, have you had an assessment with a therapist?
An assessment, yes.
Okay. So what settings did they tell you to use after the assessment?
That's a very good. Nobody. They didn't say anything about what to use. They just said, here's the machine, and it starts at 1 and it goes up to 5, and you turn it up as you need it.
Okay. Who's your provider? Vital Air?
I'm in Alberta. It's
Oh, you're in Alberta. Okay.
yeah, it's a company called Maple Respiratory Group.
Okay. So honestly, Brian, I would go back to your provider and ask them what they have on file for a prescription for you based on the assessment that was done by a therapist the last time you had one. If they haven't done a recent one and you think that maybe your requirements have changed, or you start using the prescription that they give you and it's still not enough, I would ask them to do another assessment.
Yeah.
Because I think that's like, it would be a guess if I was to tell you what to use.
Yeah.
You really should be assessed on the oxygen up walking around to see what they need to give you to maintain a level that's safe, which would be above 88.
Great. Okay. Thank you very much.
Yeah, you bet. Because really having levels, like having oxygen levels at 65% would be enough to make your RT uncomfortable. Right. So if your RT is uncomfortable, it's probably worth getting it turned up some. In the meantime, while you're waiting for them to come and see you, I would try maybe turning your oxygen up when you exert yourself, right? Try turning it up to 5 and see what you get. I think if you're desetting all the way to 65, I think in my experience, it's a pretty safe bet. You're going to need at least 5. And I think you might be actually in the above 5 liters a minute territory on exertion. Totally depends on the person. Do you have COPD or ILD?
ILD.
There we go. We're talking probably above 5 liters a minute. So if your concentrator only goes to 5, it might not be as helpful in the home, and you might have to have one that goes to 10 liters installed. However, your portable oxygen, I'm going to guess, is cylinders.
Portable oxygen. Yeah, I have portable oxygen.
Is it cylinders or a portable concentrator?
Portable concentrator.
Okay. I would crank that thing if you're using that and walking around with it. Yeah. My guess is you need more than what you're using. And maybe more than what you have the ability to get with the equipment you currently have. A reassessment with your provider would be your best bet.
Great. I'll check it out. Thanks for your help.
Yeah, you bet.
Thanks, Brian. Thanks, Chanda. That was it for questions in the chat. If anybody has any questions, please unmute yourself, say your name, and then chat away with Chanda.
Come on, I like chatting.
Or you were just so thorough that every question was answered.
You know, if you can't dazzle them with your brilliance, just throw it all out.
Yeah, any questions out there from anyone?
I have a question.
And your name?
My name's Dorothy.
Thank you.
I was assessed several years ago, and I'm wondering, I've never had to go back to have another assessment. I was just wondering if we should go in every once in a while to make sure your machine's doing what it's supposed to be doing, or like when I first got it, it seemed like it was pumping out a lot stronger. I was in that group that had to have our machines replaced. So I have a newer machine, but it doesn't seem like it's as forceful as when I first started. So should I go back and see about having another assessment, or is it like I sleep fine? I feel fine when I wake up and things like that, but I've just been wondering, should I go back and
Yeah. So, Dorothy, what kind of a machine do you have right now? Is it an automatic machine or is it a straight CPAP?
it's a straight CPAP. It's the Dream machine.
Like a Dream Station.
Dream Station, yeah, sorry.
Okay. So you were one of the ones that actually managed to get a replacement from Philips instead of going to ResMed.
It took a long time, but I got it.
Yeah, it was not a quick process for sure.
Yeah.
So yes, long story short is yes, you should probably see your provider.
Okay.
I would always recommend having that follow-up once a year, even if they're doing it remotely and they're just checking a download from the machine once a year.
Okay.
And you're going to buy your supplies online, whatever. But typically new supplies will keep everything working for you properly. So you're getting a good mask fit, which is so important to make sure that the machine is working well for you once a year. But then the follow-up with your provider just allows them to check and make sure that the pressure settings you're on are still working appropriately for you. It's not uncommon for us to have to tweak them a little bit from year to year.
Okay.
And then the good thing about that is when you come in once a year and we have to tweak it, we might be going from a pressure, say, for example, from 10 to 11, and that solves the problem. If you've gone an extended period of time without seeing somebody, 5, 6, 7 years, whatever it is, then we might be looking at a big jump. And now all of a sudden compliance is an issue because it's uncomfortable again for you. You have to get used to a very different pressure setting. It's much nicer, I think, to do it in shorter sort of or smaller adjustments.
Okay.
And then we're catching it more often as well. We don't want you to be on CPAP and still be untreated for 6 or 7 years. That's not great. If it's only doing part of its job, that's not great. We want it to do the job appropriately. The reason you may feel that it's not sort of pushing as much air at you as you did initially is that you're used to it now, right?
Oh, okay.
So your body has adjusted to it. You've totally learned to tune it out, where initially you put it on as a very strange sensation. Not only are you being told to sleep with something on your face, but something that's blowing a decent amount of pressure in your face. But over time, your body learns to tune that out just like it does anything else, right? However, there is always the possibility that your machine actually isn't putting out the pressure it should, right? If something's maybe it's a fault with the equipment, maybe a setting got tweaked by accident. It's hard to say, but having that sort of regular follow-up catches those issues more often.
Okay.
So yeah, once a year, I think at the very least, even if you're not even going to buy supplies from a provider, paying the $50 or $100 or whatever it is that they're going to charge you for the assessment, it wouldn't be a ton, is certainly worth it, I think, just to make sure that everything is still working appropriately, right? Because you want to make sure that all of those health risks that you're getting rid of, that you are actually getting rid of them, right? That we don't still have a lot of apneas, even though you're still on CPAP.
Yeah. And I think that was part of it. I kind of just expected that they would call me back to reassess everything, and they never did. So I just assumed, okay, well, I guess I don't, so, but I've been wondering about it lately. So yeah, I will do that then. Thank you very much.
Every provider is different too, in terms of what they do for follow-up. So, and unfortunately, I think we have a healthcare system now where you have to advocate for yourself.
That's true.
There's nothing wrong with calling your provider and saying, hey, I haven't seen you in a year. I need to get some supplies anyway. Can I have a nice follow-up at the same time? Right?
And if I changed providers, does that matter? Like
you can change providers. Absolutely, you can.
Okay.
You may even be able to get whatever they have on file for you from your old provider sent to the new one. They may charge you for the file. It's hard to say. At the very least, often a new provider, if you're changing, is going to need an updated prescription from your physician in order to open a file for you. Yeah. Okay,
perfect.
But beyond that, they should be able to go from there if they've got a prescription for the CPAP.
Okay.
There was something else I wanted to tell you, and now I've forgotten. It had to be super important. Yeah.
Okay. Well, thank you very much. I appreciate that. If you think of it, you can tell me later.
I will. Yes.
All right, Chanda, we have a question in the chat box that just popped up from Susan. She says that she has dry mouth at night. How should she manage this?
Susan, I'm assuming are you talking about dry mouth on oxygen or dry mouth on CPAP?
On oxygen.
On oxygen. Okay. How much oxygen are you on, hon?
Just one at night, but I have dry mouth all night long.
Okay. So there's a few things that can be going on. It's certainly the oxygen is not going to help, but at 1 liter a minute, it's fairly low. I would think its contribution to the dryness would be minimal. It's probably more likely that you're either mouth breathing, potentially snoring. That's also a possibility. Have you ever had anybody tell you snore?
I sleep alone, so no, not really.
No. Do you tend to breathe through your mouth at night? Do you know that you
am
like
a
to breathe
mouth
through
breather. Yeah.
Okay. So I think kind of your best options is like make sure you're staying well hydrated, although that's not going to help a ton if your mouth is opening and you're breathing exclusively through your mouth at night. But a good humidifier sometimes in your bedroom can help, right? And a good heated humidifier, as long as you're making sure that it's staying appropriately cleaned, is not really a risk to your health, and it might help to humidify the air. The winter especially it's cold outside, it's dry, then we're heating the air, it's even more dry. If you heat with wood, which lots of people in BC do, it's even worse. So definitely getting a decent humidifier, especially in your bedroom, can help. Alternatively, if you find that you still have a dry mouth, can I ask if you're on any heart medication?
Yes, they have added 2 new ones.
There we go. Okay.
If that's what's caused it.
Okay. So there are some heart medications that will also contribute to a dry mouth, whether you're breathing through it or not. So breathing through it certainly will make it worse. Have you ever heard of something called biotin?
Yes, I do use that.
There we go. Do you find it helps at all?
Yes. I spray it all night long.
Yeah, that would kind of be my only sort of advice, hon, unless, like, do you breathe through your mouth at night because you feel you have to? Do you have restricted flow through your nose, or you think you just relax and mouth sort of falls open?
Even at 1, I have COPD, and even at 1, my oxygen levels get up to 96, where I really would like to be up to 94, so, yeah, I don't need a lot of oxygen at night. Throughout the day I do. But yeah, at night yeah.
Yeah, I think probably humidifying your room air, honey, is probably your best bet. Having a sip of water now and then, have it on your bedside table if you're waking up with your tongue glued to the roof of your mouth. Sometimes that's going to be the only option, right?
Yeah,
yeah, short of the biotin is another good one, but those are about the only things I can think of. As long as you're sure that you're not snoring and kind of causing that extra irritation to your mouth and throat.
Yeah. I'm not asleep.
Sorry?
I'm not asleep, so I'm not snoring.
Yeah. Okay. Perfect. Yeah.
May I address that issue?
Oh, yeah. The dry mouth on oxygen, Ken?
Yes.
Sure, yeah, go for it.
As crazy as it may sound, I in fact have found that actually putting surgical tape over my mouth, and I sleep soundly and I never wake up with a dry mouth. Now I admit, if you're able, got this idea reading some book on breathing, and I found that it actually does help. I often don't go to sleep with it on, but I'll wake up and have a dry mouth and feel uncomfortable, and then I'll put it on and I'll sleep longer and more rested. And I think having a dry mouth, they say, it's really raises issues in terms of your dental care as well, because saliva is a cleansing agent, I suppose. So, for me, it's worked. I know it's, sounds a little crazy, but.
No, that's actually, when I asked her if she had to breathe through her nose or whether her mouth was just falling open,
that's what raised
I was going in the same direction. So, but my suggestion wasn't going to be tape, although they do actually make a tape specifically for that. I don't like the idea of tape, only because if you woke up in a panic and felt you needed to get your mouth open, it's not easy to do when you're kind of in a stupor. You can, however, purchase pretty easily, probably online, chin strap. So chin strap goes above your head, almost like the headgear for a CPAP mask, and down around your chin, and you adjust it until it basically will hold the weight of your chin. So if you were to relax, your mouth isn't going to fall open. However, they won't prevent you from forcing your mouth open if you wanted to. It's also another option. But if you're somebody that has a deviated septum or lots of nasal congestion, sometimes that's not an option because you have to breathe through your mouth. So it totally depends on the person.
Thanks so much for that, Ken. That was a great segue into the chin strap. And
That's a
then
good tip.
another segue into it. We have, I think it has to be our final question purely for timing. But Selena said, what about dry mouth on CPAP?
Okay. So different story. So
Yeah,
now
another
dry
segue.
mouth, and it's Selena, is that right?
Yes.
Yes. So dry mouth on CPAP can be a couple of different things. Either you need to adjust your humidifier so you're getting more humidity, okay, so that the machine isn't drying you out with all of the flow that it's giving you, or you have a mask leak. If your mask leak is significant enough, then you don't actually get much of the moisture that's coming from the humidifier because it's all bypassing the mask, it's just blowing back out. So most of the time, I would say if you've got your humidifier adjusted way up and you've still got a dry mouth, it's a mask leak. So it's either that you need to adjust the mask you have if it's relatively new, or if it's very elderly, if you've got a 5-year-old mask, it may be time to trade it in for a younger model. Did that answer your question, Selena?
Selena's still here.
Yeah.
Oh, there she is. There you are.
Yeah, kind of without knowing the specifics of how old your mask is and stuff, we're kind of going with as generic an answer as I can possibly give you.
Yeah, it was more with the old mask, and I just got a brand new one, but I will definitely look at maybe adjusting my humidity. The new mask, I'm finally sleeping really good because the old one was driving me nuts.
Yeah, mask leaks are just, they're noisy, they're annoying, and then it doesn't allow for the CPAP to do what it needs to do because it can't maintain the pressure it needs to. So yeah, for sure, replacing your supplies is going to give you the best chance of having effective therapy. Always, always. And don't be afraid to adjust the humidifier up either. If you've got a newer CPAP unit, they all come with heated tubing now. You're not going to get that condensation forming in the tubing that we would have caught in the machines, 10, 15 years ago. It was a problem. Now you can adjust the humidity up and not really worry about that, which is great. So if you need more humidity, give yourself more humidity.
Also, keep in mind that it's winter time, it's colder, the air is drier, so you might just require an increase in humidity during this season. And then when we get into spring and summer, when the weather is warmer and the air carries a bit more moisture, that also may result you in dropping how much humidity you add. Everybody is different. How you heat your home, everything can impact it. And one other thing, just from my experience, is if you find that your mask is leaking, it's brand new, if you don't clean it regularly, then that nice soft silicone doesn't seal or adhere. It doesn't adhere, but it seals to your face. So if you don't wipe it down every morning, once you take it off and clean it weekly, then it's not as soft and supple and it won't form to your face as nicely.
Yeah. Last little tip for a mask fit. If you're struggling with mask fit, leaking, dry mouth, you're on a CPAP, try loosening your mask. So we have a tendency to tweak and tweak and tweak and tighten and tighten and tighten until the cushion that's supposed to seal on your face is no longer touching your face where it's supposed to. Sometimes you have to back it off completely and start fresh to get a seal. Okay, so as long as it's a new mask and it's properly cleaned, sometimes that's your best bet, is to just start fresh with a little bit looser fit and go from there.
Perfect. All right, everyone, we've used up our time. I want to say thank you so much to Chanda. This was a wonderful presentation. I hope everybody got a lot out of it. It, I think, answered questions that we might not know we actually had. So guess what? You're going to have to come back again. Okay. So we're just going to say
I would be thrilled to do it again.
Wonderful. So we will say goodbye to everyone. Thank you for attending. And a reminder, next month on the 19th, at 10 a.m., we are having Jacqueline and Tracy. If you already have experienced this presentation with them, you are lucky. Please come again, but it is Harmonicas for Health, and you'll hear some musical tunes. Okay.